All right, guys, so we're doing 3 chapters today. I don't like the title of this chapter. It's labeled medical overview, but it should just be labeled like infectious diseases because that's pretty much all this chapter talks about. So we'll cover this. We'll go into endocrine and immunology. We'll spend a little more time on those because we're going to talk about the SUGs. We're going to talk about diabetes. We're going to know all about that. And the biggest thing in immunology is going to be anaphylaxis. Okay, so we're going to get those covered today. Guys, any questions recapping cardiovascular or respiratory emergencies? This schedule is a little bit different. Typically, cardiovascular and respiratory are in this module. All of the medical emergencies are kind of clumped together, but we separated them this time. Everybody good on MIs, recognizing one, what to do for one? Everybody good with your cardiac arrest algorithms, asthma, pulmonary edema, congestive heart failure, pulmonary embolism. Yes, sir.
This is kind of unrelated to shock. What's the difference between a simple and or spontaneous tension pneumo? They get like tension pneumos like that.
Yes.
So, like,
So guys, remember spontaneous pneumothorax. Our man Chris here, he is very much more prone to have a spontaneous pneumothorax. Typically, you will obtain a pneumothorax through some trauma, right? A GSW, blunt force, stabbing, something like that. But there is such a thing where it's a very tall and slender build males are prone to, just because he doesn't get stabbed in the chest doesn't mean he can't have a pneumothorax. I actually ran a spontaneous pneumo in the field, almost exact same stature as him. He worked at Taco Bell. He was lifting the syrup box to replace the fountain drink syrup. If anybody's ever worked in as a server, they know what I'm talking about. And just that simple movement of that trauma or that physical activity just spontaneously disconnected severed the connection between the pleura. Now, that's the definition of a spontaneous pneumo, guys. I don't care what kind of pneumo, whether it's a pneumothorax, a hemothorax, or a pneumothorax, or a spontaneous pneumothorax. If it's not dealt with by calling ALS and having that pleural decompression, like sticking that big old needle in the chest, every single pneumo will it will turn into a tension pneumo. Okay, because guys, what happens with a tension pneumothorax?
Your artery or maybe vessel shut.
Right. So we have that pneumothorax there. If we don't relieve that pressure builds and builds and builds inside the thoracic cavity, and then it starts to put pressure on the greater vessels, the heart, and the good lung. So no matter what kind of pneumo is present, if we don't deal with it, if we don't decompress, it will turn into a tension pneumothorax. And that's what kills you. Okay. Everybody go with everything else. Pneumonia, tuberculosis.
Will you?
Different lung count, what they mean. Getting a 12 lead.
I'm definitely going to need to go over the 12 lead because for some reason that's not sticking too well.
Okay, so what about it?
The terminology that you gave us to kind of remember how to place everything, if for some reason I don't know how I lost it, but it didn't quite stick with me and I need that reminder on how that went.
Okay, so you've got 10 different stickers, electrodes, or leads, if you will. The 4 limb leads, you're going to place typically right here on the deltoid area of the right and left arm. And then the leg leads are going to go in the lower quadrant of that part of the abdomen. So right leg would go in the right lower quadrant, left leg would go in the left lower quadrant. You've got smoke over fire. So you've got the black lead, and then you've got the red colored lead. And then you've got a white colored lead and a green lead, so clouds over grass. My stupid analogy that hopefully you guys will remember. It ain't right for something to be on fire. So the smoke over fire is going to be on the left side of the body. Clouds over grass will be on the right side of the body. V1 and V2 are fourth intercostal space, just mirroring each other on each side of the sternum. So V1's on the right side of the sternum, V2's on the left side of the sternum. Your V4, you're going to skip V3 for now. midclavicular, fifth intercostal space, and then V5 and V6 will follow that costal curvature, that fifth intercostal curvature, and then V3, you literally make a diagonal line between V2 and V4.
So the expectation for us is to know them first.
Yes. Got to know where to place them, because if you've got them all wonky, it can give you a misinterpretation. Because you guys can obtain, you cannot do what with 12 leads? Interpret.
Interpret.
You got to send it to either ALS or medical director.
Do V5 and V6 again, I'm sorry.
So V4 is midclavicular,
Midclavicular.
and then 5 and 6 just follow that fifth intercostal curvature going towards the axillary line.
I couldn't for the life of me remember. Okay.
Things like, are we gonna have material to do that?
We
here,
can,
or-
yeah. So any downtime that we have for any of these lecture days or the next lab time, you can, because I think some of you got some playtime with the monitor. But yeah, I can get it out for you guys. Okay. Everybody's 110% clear on everything cardiovascular and respiratory.
No.
No.
Okay.
I'm not gonna say 110%, but
Okay, that's logical. All right. So guys, going through the different types of medical emergencies. I'm recording, right? Yes. All right. This is going to go back to MedTerm, right? Any type of root word that you see is going to pertain to a different system or a different type of the body. Respiratory is dealing with the respiratory system, okay? You might see the other P word that refers to the lungs. Not pneumo, huh? Pulmonary, all right, that means referring to the respiratory system of the lungs. Cardiovascular, heart and vessels, circulatory system. Neurologic, brain, all right, so any type of neurological emergency is referring to something that's not functioning appropriately in the brain. Gastrointestinal, anything digestive, stomach, intestinal tract, colon, all that stuff. Pancreatitis, appendix, because all of those organs also deal with contributing to digestion.
Does that include the liver as well?
That's kind of its own separate thing. Urologic, relating to the kidneys, okay. Endocrine, glands, particularly something's not working right, starts with an H. Hormones, okay. Hematologic, blood. Immunologic, immune system. Toxicologic, toxins, all right, either intentional or unintentional. And gynecologic, female reproductive, all right. So guys, this is just a chart of some major issues, some big medical emergencies we can have per each system. It doesn't mean that everything on this chart is the only thing that can go wrong with these systems, but these are definitely some things that you absolutely need to be 110% familiar with, recognizing and treating. Okay, and we're carving out, getting there, going through this module. All right, so is everybody clear that when we talk about an MOI, that means what? Mechanism of injury. That's going to deal with what kind of emergency? Trauma. Okay, so when we're doing that scene size of that patient assessment that you guys have been practicing like 24/7, right?
Yeah.
When you say MOI or NOI, all right, now that we're in this medical module, we're not going to be really dealing with injuries. So the NOI, the nature of illness, is going to be pertaining to medical emergencies. Okay. Now, let me just asterisk. We are not going to be mean. Well, we might give you some mean, hard practice scenarios, but when it comes to an instructor checkoff and registry, a medical assessment is just going to be a medical emergency. A trauma assessment is just going to be a trauma injury. Okay, we're not going to give you both at registry in class. That does not mean that you're not going to have a patient with both out in the field. All right, give me an example of both a medical and a trauma patient. Somebody who is hypoglycemic, has a syncopal episode and falls down a flight of stairs and has a major gash on their head. What else?
Anybody that was in a car accident and had a seizure behind the wheel.
Anybody that has a seizure while they're driving, which is probably not the best idea, right? But has an MVC because they went unresponsive behind the wheel, definitely. All right, so just a few of the ones that I've ran, hypoglycemic leading to an MVC, shooting up while driving, leading to an MVC, that'll do it too. Strokes, secondary, or falls, secondaries to strokes, heart attacks, all that stuff. So we're gonna be nice to you guys, registry's gonna be nice to you guys, but don't get tunnel vision when you go out in the real world and you have a patient just because it comes out as a fall. Don't treat it just as a fall. What if they're unconscious or if they're altered? What are some things you have to get to make sure you're not missing anything? Okay, so ABCs. But sometimes a lot of people neglect these things on trauma patients. What do you think? Okay, so maybe a sample history, if we can get it, huh? Particularly what?
Glucose.
Sugar. Okay. Oh, it's just an MVC. It explains it was a head-on collision. People don't check a sugar. Oh, maybe that's the reason we had the head-on collision. And then also, what else do you need to check that can tell us a lot about what's going on with the patient? Pupils. Okay. MVC, if you've got pinpoint pupils with an MVC, okay, let's try some Narcan. We might wake that patient up. All right, so don't get tunnel vision. Every vital, every assessment, every question, every patient, every time. Guys, you don't want to miss anything that can cause demise to your patient. Okay. Again, do not get that tunnel vision. Guys, our dispatch is great, but they only give us the information that the caller is giving them, right? So another thing to remember, guys, these patients that you go out there, they're not going to have this textbook knowledge that you do, right? They're going to get on scene. They're going to tell you what they're feeling. Okay? It could be a 60-year-old female who's having abdominal pain. She has no clue. It could be an MI, right? Don't get focused on, oh, this is her stomach. Her stomach's hurting. It's a GI problem. And omit getting a 12 lead, right? Just because somebody's having some difficulty breathing doesn't mean it has to be asthma related or anything like that. Get that history, see if it could be a PE. All right, so make sure we're getting a thorough history. Don't get tunnel vision. We've kind of already talked about this in the first few chapters, right? Okay. Guys, scene safety, nothing changes with scene safety. If your scene is not safe, if it is not secure, you don't enter that scene. All right. A lot of people think that scene safety deals specifically with trauma, like if it's a GSW or a stabbing or an assault or anything like that. But, you know, we could have some stressful, hostile situations in our environment that causes our patient to have a heart attack, right? So this, you will never waver on scene safety. Okay. If you at any point in time question your scene safety, then that's no longer your patient. Get on the radio dispatch, get APD or any other resources you need involved to make sure that you don't become a patient yourself. Everybody good with what the general impression is? How we kind of determine that? What do I want to know when I come up on scene? My general impression is going to be what?
Person response, number of patients.
Okay, definitely level of responsiveness. All right, if I have a patient who's looking me in the eye when I walk through the door and they're sitting there cool as a cucumber, they're not pale, cool, clammy, diaphoretic, working to breathe, are my red flags going off just yet? No. Okay. So that initial interaction with that patient should start to say, oh, hey, we maybe need to speed this up. This patient could be critical, or hey, I can stay and play with this patient, right? Everyone good on ABCs? How we assess those, what we're looking for, the normal rate, rhythm, and quality of both breathing and circulation. Guys, who needs an adjunct in the world of patient care?
Unresponsive.
Unresponsive, unconscious, right? Because if they're that bad neurologically, they're not that intact, then who's to say they're gonna be able to protect their airway? So don't forget your adjuncts. Everybody good with oxygen therapy? The different devices, the different flow rates, when we need to use the different devices?
I have a question. So on the test, he asked like, it seems like a suspect of a heart attack, and he wasn't short of breath or anything, but his oxygen saturation was like 93%. And it says, how would you proceed? But I give him like the nasal one, like 2 to 4 liters.
So what's our goal range for that SpO2? 95 to 100. Even if your patient is having a heart attack, like if you confirm, you send that 12 lead off to the doc and he's like, yeah, he's having a STEMI. All right, if his O2 stat is at 93, we only want to get him to that 95 to 100 range, right? So does he need a non-rebreather at 10 to 15 liters per minute to get there? No, he just needs a little bump to get him up to that 95 bare minimum. So yes, nasal cannula, 2 to 4 liters. Because guys, that's another thing that we've come away from through research and the evolution of EMS. It used to be if you were having a heart attack, I don't care if your pulse ox was 99%, you got a non-rebreather. You got high flow O2, 10 to 15 liters a minute. Okay. Over time, we found that high flow oxygen can lead to vasoconstriction. Is vasoconstriction a good thing to have during a heart attack?
Not really, no.
Right? So yeah, we just want whatever that patient needs, a big bump or a little bump to get them to 95 to 100, no matter what's going on with the patient, is what we're gonna give them. Everybody good with load and go versus stay and play mentality? How long do you have to be off of your scene ideally for critical patient? 10 minutes?
10 minutes.
Where are we taking these patients? What if it's a trauma patient? Trauma facility. What if they're having a stroke? Stroke center. What if they're having a heart attack? STEMI facility. Guys, make sure you're taking the patient to an appropriate destination that can handle whatever's going on with them.
One of the contents in the book was the patient asked to go to a particular hospital.
Uh-huh.
You guys, so if they're non-critical and they ask to go to some other hospital because they've been there before, do you guys do that? Will we do that?
It depends. We, if I pick up somebody downtown Atlanta and they're saying, hey, my doctor's at Southern Regional. Okay, that's a significant drive and a significant distance outside of our jurisdiction. So depending, I can call my supervisor and say, hey, this is what's going on with the patients. They're requesting transport here. Do you approve or deny? But yeah, we're only obligated as a 911 service to transport within our territory. So sometimes the patients don't like to hear that. If it's nothing that's life-threatening, then we can say if you would rather, if you want to go to that hospital, if my supervisor denies that transport, you can drive yourself or you can have somebody else drive you, but we just can't take you there type thing. So we always try to see if it's feasible, but most of the time it's not, just because we don't have enough trucks
I get it.
to take one out of territory. Yeah.
That's why I was surprised when we heard it said that we shouldn't.
You can ask. Guys, history taking, everyone good with what SAMPLE stands for? I know some of y'all are struggling during patient assessment. SAMPLE stands for? Okay, collectively that was right. All right, what does OPQRST stand for?
Onset, modification, palliation, quality.
All right, so guys, this is again, we're in the medical module, okay? Does OPQRST apply to medical patients?
Yeah.
Yes. OPQRST doesn't really so much apply to who? Trauma,
My
right?
life hurts. Thing's broken.
Yeah, my ankle hurts. Okay, well, can you tell me, does that radiate anywhere? No, dude, I can see that your bone is sticking out of your ankle. I understand that's why you're having pain there. Right, we have to remember this OPQRST because a lot of these signs and symptoms for these medical problems can do what? Okay, so definitely give us puzzle pieces, but can also do what? That we need to ask questions to clarify things.
Rule out the really bad thing.
They can mimic other problems. right? If you have a 6-year-old female who's having abdominal pain, well, let's get a little bit more of her medical history. Let's ask her what kind of pain is she feeling, because it could be something with the GI system, or it could be a heart attack, right? If you have a patient who's acting altered, guys, there's 27,000 different things that can go wrong with the body and its different systems to make your patient appear altered. So we've really got to hone in on that sample and that OPQRST along with our surroundings and our assessment findings to get these puzzle pieces together, because medical can be tricky sometimes. It can be misleading sometimes. Trauma's not. Trauma's straightforward. If it's broken, it's bleeding and it hurts, right? So make sure that you're very aware what these acronyms stand for, why it's important to get them, to get that knowledge, because we definitely need this for our differential diagnosis. Don't worry about tacos. Now I want tacos for lunch. All right, again, guys, who gets a head-to-toe assessment?
Trauma, unconscious.
Okay, so unconscious for sure. Can a patient be unconscious secondary to trauma and medical, and or medical?
Yeah.
All right, so if you're unconscious, unresponsive, you get a head-to-toe. All right, who else? If you're significantly altered to the point where what? You don't trust them, okay, so they can't effectively communicate, right? They can't effectively answer your questions. They're not really following commands. They can't tell you what hurts. They can't give you medical history. If we're altered to that point, then yeah, I'm gonna do a head to toe because I need to figure out what's going on. I can't get that information from my patient. All right, who else gets a head to toe?
Distracting injuries.
Distracting injuries, right? If you've got bilateral femur fractures, that hurts a crap ton, right? They might be focused on the pain from that and not realize that they have other injuries or pain elsewhere, right? But guys, mostly for this medical module, significantly altered to the point they can't communicate or unconscious unresponsive is going to get a head to toe. Okay, everyone different, good with the difference between head to toe and focused assessment?
In a focused assessment, you still just do like the same mechanical things, but you just only do it on that one region.
Now, the mechanical things, maybe not so much because it's not going to be trauma for this module, but we'll talk about the specific further assessment that you would do per system. But yeah, you're not going to do a head to toe. You're just going to go say, oh, you have chest pain? Okay, let me go zone in on the chest. Let me get a 12 lead. Let me listen to lung sounds. Let me, look, listen, feel type thing. All right, guys, golden 5 vitals. What do you get on every single patient?
Blood pressure.
Respiratory rate, heart rate, CO2 and BGL.
Blood pressure, heart rate, respiratory rate, SpO2 and BGL. What is the 6th variable one that is applicable to your patient? Temperature. Okay, so if you have a significantly hot patient or a significantly cold patient, let's throw temperature in there. But usually for 92% of the patients, we're not going to worry about a temp if they're anywhere around that normal warm feeling. All right, AirEvacs. Guys, if you work for the City of Atlanta for Grady EMS, you think you're going to need to call in a bunch of birds. No. Okay, why?
Where's the helicopter gonna land to pick the patient up in the first place?
Oh, they get creative. They get very creative. All right, but guys, anywhere within Grady's territory, the longest transport time you're ever going to have to a hospital is 15 minutes. And that's generous. We're going lights and sirens, a controlled, smooth, nice lights and sirens ride. It's not going to take us that long to get to any given hospital within our territory. We are a very urban setting. Now, if you go and you work in Pike County, that Grady just took over, okay, they are not urban. They're very rural. So if you're an extended time frame away from the hospital, you have a critical patient, you've got a critical trauma patient, you have got a patient who's having a heart attack or a stroke, and you're a significant amount of time away from an appropriate facility, then yes, you're going to get an AirEvac in. We'll talk about the logistics of getting that in the works and what to know about when it comes on scene later. But for now, you just need to know you'll need an AirEvac when you have a patient who is an extended amount of time away from an appropriate facility. Or if it's like a terrain issue, right? If you guys are, you're working for the mountains, you can't drive an ambulance up the mountain side type thing. If it's an extrication because of terrain, that would also be something to keep in mind, but we don't really worry about that in Atlanta either.
We put, I live in Newtown, right, so a lot of helicopter traffic, how many of those is actually patients transported?
So a lot of the helicopter traffic that you'll see, especially at Grady or any other hospitals, are inter-facility transports. So let's say, for example, South Georgia, somebody got into a significant car accident for whatever reason, they didn't do an air evac from scene to Grady. They can do, let's say they transfer to a community hospital. They stabilize that patient, the community hospital is like, dude, we can't handle this trauma patient. They can go pick up from the community hospital and then bring them to Grady. Guys, all over the Southeast, we get patients flown in to Grady for the stroke center, the burn center, all that kind of stuff. Okay.
Probably a different level of certification would be a paramedic.
Critical care. Okay, infectious diseases. What is this? Diseases that can be transmitted from one person to another, or sometimes from one species to another. Okay.
How pertinent and topical.
Imagine that. So guys, understand what needs to come into play here with these IDs, what we refer to as an infectious disease. These ID patients. BSI, right? You've got to make sure you're properly protecting yourself. That starts with getting your vaccinations, hand hygiene, all of the PPE we have, right? Masks, gloves, gowns, face shields, all that jazz. What do we need to keep in mind with these patients who have any type of infectious diseases when it comes to the legality part of our treatment? We need to be careful that we don't commit what? Okay, so HIPAA for sure. Neglect, right? I think I told you guys during that chapter, there was an employee who used to work at Grady who refused to start an IV on a patient who was HIV positive. That patient needed fluids and medications because they were sick. And they said, ooh, I don't want any further chance of cross-contaminating and getting HIV from you, so I'm not going to start an IV and treat you. That's neglect. That is all 50 shades of wrong with that. Okay, so remember your medical terms, remember your ethical and moral terms when it comes to this. We don't neglect patient care just because of their medical history. Okay. Okay, here we go. Define an epidemic. If any of you get these terminologies wrong in this day and age, we got problems. What's an epidemic?
Disease that's growing got out of control significantly more than expected.
Okay, so yes, but it is contained. It's a local outbreak, if you will. Okay, so typically, every year we see like local state by state, well, I guess, yeah, technically it's still an epidemic, like flu. Like the flu season, guys, that kills a lot of people each year, the immunocompromised, all that jazz. Once we get to a global scale, once we start crossing continent and country borders with this particular disease, it moves into a pandemic. Can anyone give me an example of a pandemic? All right, guys, so we're right in the middle of a pandemic still. Okay, so coronavirus, COVID-19 is the best current events example of a pandemic. Okay. The flu. What do you guys know about the flu? Technical term is influenza. All right, what goes on with this?
Virus, it mutates pretty heavily, so there's a new strain every year or two or three.
Genetic exchange happens between animals and humans.
Okay. All right, so guys, we hear about this every flu and cold season, right? When it starts to get cold outside, those little cootie germs, that's their wheelhouse, right? Influenza, it's going to be mostly respiratory driven. It really affects the lungs. All right. But yeah, so the way that the flu works, guys, all of these bugs, these viruses and these bacteria are scarily smart. Okay. They have evolved and evolved and evolved over the past X amount of years that we've known about them. Okay. So particularly with the flu, it evolves and it mutates as a strain, typically every year or so. How do you guys think the flu vaccine works? You go and you get the shot and you're just immune, you will not ever get it?
No.
No.
The flu that was, here it's usually the flu that was most common in the Southern Hemisphere last winter for them.
So guys, what the CDC does is it looks back on the previous flu season and says, okay, strain A and C through A, B, C, D, E, F, let's say, strains A and C were the most predominant strains. Those were the heavy hitters, and they developed a vaccine to be resistant against those strains. Okay? Doesn't mean that you won't get infected by strain D and you still succumb to or not succumb, hopefully not, but you still get sick from that specific strain of the flu. They just take their best educated guess as to which ones are going to wreak havoc this particular year, and those are the ones that they develop the vaccine for. If you guys, when you get it, if you go through this course, you will have to get it this fall. If you don't already, you should. But when you get it, sometimes you will look and see, oh, it's a quad vaccine, which means it protects against 4 different strains, or it's a tri-vaccine. So that's how the vaccine works. Okay, guys, how's the flu spread? Droplet precaution, if you don't cover your mouth, if you're sneezing, coughing all over people. So what do you think that we might need to think about with PPE with these patients? Masks. Okay, what kind for me? N95, and what for the patient? Surgical. Guys, any of these infectious diseases that we're going to talk about today, all right, typically if you're an adult patient, if you're healthy, these are just going to be an inconvenience, right? You're not going to feel well for a week or so. You'll bounce back, you'll get over it in your body. The immune system kicks into gear, we fight it off, we're good to go. Who am I really, really concerned about when it comes to a simple things such as the flu?
The children and the elderly.
Immunocompromised patients, right? That includes pediatrics, because their immune system hasn't what yet? Fully developed. And that also includes geriatrics, because what's going on with their immune system? It's just not working as well, right? Who else is an immunocompromised patient?
HIV and transplants.
Okay, anyone who has HIV or AIDS directly
Kidney
targets
disease.
the immune system. So they're going to be immunocompromised. Anyone who's recently had a transplant, okay, because their body is on high alert, high demand, trying to keep that organ sustainable and not trying to attack it and kill it off, right? Who else? Cancer patients. Why? Particularly what?
Chemotherapy.
Chemo. All right, so patients who are having chemotherapy, any type of autoimmune disease, guys, that's a big umbrella. We need to ask our patient, do you have anything that would cause you to be immunocompromised? Okay. Because this can be deadly. Typically what will happen with the flu is it'll develop into pneumonia because the body can't fight it off in the flu stage. It'll evolve, it'll be pneumonia. Their body can't kick it, they die from the ammonia or pneumonia. Okay. H1N1 is the public was very much aware of the fact that these diseases could hop over to from species to species. All right, so the swine flu was initially only affecting what? Pigs. Okay, that strain evolved and said, ooh, I don't like pigs anymore. I'm going to hop over to humans and wreak havoc in humans. Okay, so that is a very true statement about some of these infectious diseases is that they can mutate from just directly affecting animals to now affecting humans. Because guys, typically if you get the flu, all right, or if you get pneumonia or whatever, if you have a pet in the house, does your dog get the flu too?
No.
No. Typically those bugs and those viruses are kind of separated by species, but sometimes they can evolve. And that's where it gets a little dicey because everything is brand new, everything is unknown. We have to figure out this virus or this strain so we can start effectively treating it. Okay, so that's kind of how our current situation evolved. We were not fully aware as to how to treat the coronavirus because it didn't affect humans for the longest time. Now we have to see how it interacts with our bodies, all of that jazz that you can hear about all over the news. All right, herpes simplex, guys, this is a virus strain that a lot more people carry than a lot of people think. It can present in the form of what? Cold sores. So if you are very prone to getting cold sores, you get cold sores a lot, that is because you have the herpes, typically herpes 1 simplex virus living in your body. Okay, guys? With a lot, not a lot, but with some of these viruses, once it gets in your system, it stays in your system. Okay, so that's like some of these STDs that we hear about that are derivative from the herpes simplex as well. Once you have it, you have it. Okay, it's just in your body. It will start to kind of present itself if you start to have some immune problems, like if you have a cold or anything. That's why they call it a cold sore, because it'll typically pop up when your immune system's kind of under attack or suppressed. You can see, again, like I said, the form of genital herpes, bodily fluid exchange is how we get this transmitted. Okay. Also, what is a derivative of a herpes complex? Chickenpox. Okay, it's not the same type of virus. So if you've ever had chickenpox, it doesn't mean that you're going to have genital herpes or cold sores, but it's in kind of the same family. So, just a fun fact. HIV. Okay, what does HIV stand for?
Human immunodeficiency virus.
Human immunodeficiency virus. All right. So guys, this is going to be the kind of the precursor to what? To AIDS. All right, we'll get there in a second. There's no vaccine for HIV yet, guys. We have made crazy strides in pharmaceuticals and technology and treatment with HIV. If you do have a patient who is HIV, it's very likely that they are on a medication that suppresses the virus to the point where it's not really detectable, if you will, if they draw blood, or they won't really be symptomatic. But like I said, in addition to the herpes, once you have this virus in your body, it's there to stay. We don't eradicate it. We just kind of suppress the symptoms. Okay. So again, these patients could be immunosuppressed. So a patient who has HIV, if they get a common cold, even that's kind of scary territory for them. It could evolve into the flu, could evolve into pneumonia. It could be deadly for these type of patients. Okay. Again, used to, guys, HIV was a death sentence within a year of getting diagnosed. All right, so it was really brought to light back in the early 90s. If you guys remember any of that, people literally treated these HIV patients and these AIDS patients like they had leprosy. They wouldn't touch them, like even physical contacts. They wouldn't have anything to do with them because, again, they were just learning. They didn't know how it was spread, all that stuff. But you can have HIV these days and have an almost completely normal life expectancy if you're on this medication and these treatments. Okay. Not easily transmitted in the work setting, but how do we transmit this? Blood and bodily fluids. Okay, so again, guys, just PPE. You shouldn't have to have a second thought about just baseline gloves, because you should have gloves for every single patient. Okay. If you do have a patient who reveals to you in their medical history that they do have a communicable disease or anything such as HIV, then okay, maybe if you feel comfortable, you can put a mask on as well. If you're dealing with any type of blood with the patient. Guys, typically, especially if you're getting like a glucose, what should you have on? Gloves. All right, so it shouldn't be much of an issue, but I usually, when you go on to A or paramedic, if you're doing anything that's more invasive, I will ask the patient, hey, do you have anything in your body that can hurt me if I come in contact with your blood? Anything like that, okay? Anything that can make me sick, because sometimes HIV is still kind of a taboo, like weird, awkward thing to talk about. All right, so you might see that we refer to in the medical field patients who are HIV positive as what? Does anybody know? These are blank patients. High five patients. Okay, so high,
Okay.
Roman numeral for 5. Okay. Again, if you're coming over the radio, because it is a piece of information. If you have a trauma patient who has several wounds and there's a lot of blood involved in this patient's care, or if you have a medical patient who's vomiting blood or something's going on and there's a lot of bodily fluids involved in this call, if we can confirm from the patient or any other type of chart or bystanders or anything like that, the patient does have a communicable disease, is that something we want to mention to the hospital?
Yes.
Okay, because if I'm activating a trauma alert and I've got 3 GSWs and my dude's bleeding all over the place, okay, I want to give them a heads up that they might want to put on an additional layer or additional amount of PPE. And usually going over the radio, hey, I got an HIV positive patient, is still a little taboo. Okay, so just say, activating a trauma alert, blah, blah, blah. Be advised, this is a high 5 patient.
So,
Medical personnel knows what that means. Or I heard from one of my other patients, or my other students, house in Virginia. If you say this patient has a house in Virginia, that some medical personnel can understand HIV. But yeah, I hadn't heard that until my student brought it up, but typically we say it's a high 5 patient. So we're relaying that information, but we're not trying to
So, Professor A? Professor A?
Yes.
So when we're at work now, I know now on the radios, if we have an HIV patient, we just tell them to use universal precautions. And that tells them that the patient has HIV.
Okay, that's a newer one, but it makes sense. Yeah, I would, if you say use universal precautions, if that's a new thing, they should pick up on that. But just in that verbal report, when you get to the hospital, I would just add in, high 5 patient, or, tuberculosis or meningitis or whatever that specific communicable disease is.
so what are the things you carry with you when you're going to escalate your personnel?
The things I carry with me.
Well, I'm just trying to think, so you go on site, right, and you got your normal stuff.
Mhm.
So you gotta be carrying something so that when you have that, you identify greater risk, whether you're gonna put something else on, right? Or not, I mean, I'm trying to follow
Ideally,
through, right?
yes. And guys, dispatch does do a good job. If there's profuse amount, like if there's just a crap ton of blood on scene,
So I get that.
then they usually relay that. So that can give us a heads up, hey, maybe we want to double glove it. In all reality, unless you bring your own personal stash, now with everything going on, it's a little bit different. We have a little bit more PPE on the trucks, but usually the only thing that extra that we will carry is going to be that face shield or the goggles. Because guys, remember, it's your eyes have mucosal membranes as well. Okay, that's
a lot of splash protection.
the one and only time I had an exposure in my career. It was in my eyes. So make sure that if you have your own set of safety goggles, face shield, whatever, if dispatch is telling you, hey, we got a bunch of blood, then consider putting that on. Make sure you're putting your sharps in the sharps container. I cannot stress that enough, guys, especially when you move on to A, if you're starting IVs, Okay, the second you remove that needle from the patient's skin, where does it go? In the sharps. Do not put it on the bench seat. Don't put it on the captain's seat. Don't put it on the patient's stretcher and be like, oh, hey, I'll remember to throw that away as soon as I get this done. Guys, it has got to be ingrained in your muscle memory. The second you're done with that needle, it goes in the sharps, because this is the biggest reason healthcare workers get exposed to these communicable diseases are dirty needle sticks. Okay, so watch out for your partner too. If they're an A or a medic, if they're not putting something in the sharps, be like, hey dude, that needs to go in the sharps, or go do it yourself. Because you don't want to have a chaotic call and forget about that needle that you sat to the side and don't clean it up. And then next time you go to sit on a bench seat to talk to your patient, you sit on that needle. Okay, those dirty needle sticks are a very, very big problem when it comes to healthcare workers being exposed.
Is the sharps container usually like mounted on the stretcher or in a jump bag or
Or the what?
If you're- the sharps container, if you're not actually
No.
on the rig,
You should have one in your jump bag.
Okay.
But there are usually 2 mounted in the back of the truck. Don't put it, for the love of Pete, don't have a trash pocket. If any of you guys heard Instructor Anderson say to have a trash pocket, don't have a trash pocket. I mean, you can, but not for, no. No. Guys, just follow your agency's protocols if you do have an exposure. Typically, that's going to be, unless you are immediately rendered unable to provide patient care, you're going to continue your patient care until you transfer that patient over. You'll get in touch with your supervisor and be like, hey, I had an exposure. I need to be taken out of service. They'll come meet you. They'll do a paper packet. You'll go get your blood drawn with the patient's consent. The patient's blood will be drawn. They can run the patient's blood work to see if there's anything that y'all need to be worried about. And then you go from there. Okay. Hepatitis. Any questions on HIV? I don't know of anyone who takes it in the healthcare field just to reduce exposure. And I think that's solely because of the fact that it's a newer drug. Like, long-term studies haven't been performed on any type of negative side effects. But like the PrEP pill is a big one. Yeah, I don't know of anyone who electively takes it in healthcare, aside from if they have HIV. But I guess maybe further down the road, it could be something to consider. Okay. Hepatitis, guys, what does this deal with? Liver. Okay, so the liver is not functioning appropriately. Guys, there's different hep A, B, C, all the different mnemonics. So it gets inflamed, it gets infected, it does not work properly. Guys, what does the liver do for us? It's a filter. Okay, it's a filtration system for the body. So you'll start to see the earlier signs: loss of appetite, vomiting, fever, fatigue. It'll eventually lead into that jaundice. What is this? Yellowing of the pigmentation of the patient. All right, guys, it can be the skin. What else can appear to be yellow? The sclera, whites of your eyes will turn a very yellow color. The more yellow in color, the further along we are in the progression of the failure or the effectiveness of the liver. Okay. Again, it's a filtration system. If it is not working appropriately, they will be susceptible to little viruses and bugs that can get into the body. That would normally be just kind of an annoyance. Can be detrimental to these patients. There are certain types of hepatitis that are not contagious, right? But again, if your patient across the board says they do have hepatitis, treat them like they are contagious. And you should treat every single patient, I don't care anything about their medical history, like they are contagious, right? So bare minimum, PPE, gloves, all right? Be responsible and have common sense when it comes to bodily substance exposures, the sharps in the sharps container, all that stuff, right? You guys are having you have had the vaccines. When it comes to hepatitis, there are some available. We required them for this program. So they are out there. So here's just a little chart, goes through A, B, C, and D. Tells you the route, how they're transmitted, how you can acquire these different hepatitis strands. All right, guys, what's an incubation period?
That means the time it basically lays dormant in your system.
So, for example, hepatitis B has a 4 to 12 week incubation period. That means that you could have an exposure on April 1st, okay? You might not show signs and symptoms of that hepatitis strain being in your system until up to 3 months later, okay? So guys, I just used I would imagine the most understandable, relatable analogy. Just treat it like an STD. If you have unprotected sex with somebody who has any type of STD, you can go several weeks without knowing that you have it. And if during those several weeks, or in this case, up to months, you're having unprotected sex or sharing drug needles or doing whatever, exposing and swapping out that bodily fluid, you're infecting every single person you come in contact with before you even know that you have it. Okay, so this incubation period is something that can throw a lot of these patients for a loop. They have no idea they have it. They don't know until up to 3 months later, and they're like, oh crap, I could have come in contact, I could have spread it, all that jazz. Okay. Okay. Am I scaring you guys yet? All right, meningitis. What is meningitis? Okay, so there is a protective barrier, a protective layer that surrounds the brain and the spinal cord. Okay, that's called the meninges. All right, so if we have a virus or a bacteria that gets into our system and infiltrates and targets that meningeal lining around the brain or the spinal cord and penetrates, like gets through or deteriorates that lining and gets to that spinal cord or gets to the brain, we got some big problems. Okay, so that's what meningitis is. Again, inflammation-itis of the meningeal coverings. Okay, so that's bringing back to a med term. Fever, headache, sometimes altered mental status, lethargy. Guys, what does that mean? If I say a patient is presenting with lethargy or my patient is lethargic.
Sluggish, low energy.
So there's a difference between tired and lethargic, right? Lethargic is just you're having an extended period. You are so fatigued that it takes you, a very long time to verbally respond or physically do anything. All right. But yeah, so lethargy is a big symptom of meningitis or sign of meningitis. Guys, you have got a cardinal sign/symptom that if your patient has a low grade or a high grade fever, they just say, man, I just feel tired. I don't know what's wrong with me. I don't feel good. I don't feel right. If your patient says, on top of everything else, this, okay, guys, if they have their neck hurts whenever they move their neck, or they physically are restricted to moving their neck because it is so stiff, if they physically can't, or if it hurts when they do, that is a very alarming piece of information to get from a patient who has all of these other signs and symptoms, right? If I go up to a patient and, she calls me and says, man, my neck hurts, they don't have any other sign or symptoms, I think I might have just slept wrong. Am I freaking out that she has meningitis? Probably not. But
Is it much different than like a muscular pain?
it's just stiff. Like it does have a pain to it, but it's just like, it's almost like there's like a door jam,
Yeah.
and it's just very hard or very painful. It's more of like an achy sensation, but could be confused with like I slept wrong on my neck. But again, that's why we put it on top of all of the other signs and symptoms. Okay. So meningococcal meningitis is the most contagious. This is going to be a bacterial form. There is a difference between a virus and a bacterial form of meningitis. Bacterial is not the best kind. That's the worst of the two to have. Can be very detrimental. They can be treated with antibiotics. Guys, this can be contagious, because are we going to be able to do blood draws out in the field and be like, okay, it's viral or it's bacterial. If it's viral, I'm not really worried about catching it. It's not really contagious. But if it's bacterial, I'm really worried. Like, can we do that? Do we have that luxury? No. So how should we treat these patients?
Worst case.
Treat them like they're contagious, right? That means an N95 for me and a surgical mask for the patient. This is also something you want to alert the hospital that you are bringing in a possible positive meningitis patient. Because what are they going to do with that information? Prepare for it how? PPE, yeah, but what else? Okay, so they might have maybe phlebotomy, right there, getting ready to draw that blood because it takes a while for those tests to come back. But what else are they going to do with that information? Just like if I, tell tuberculosis is another one. Bringing a possible positive TB patient, possible positive meningitis. Where do you think those patients are going to go? They're going to go to isolation, because that ER does not want patient 0, right, coming in to an ER that has people who are not infected and infecting everyone that they're around. So they will send that patient to usually like a decon area and put them in an isolation room. Okay, if you roll up and your patient's got a surgical mask, and you've already exposed them, they sat in triage or they sat in the waiting room, you're like, oh yeah, by the way, that dude probably has meningitis, or that dude probably has TB. Not a good day for you. Okay, so that's why we're relaying this information. TB. All right, what is TB? Tuberculosis. How does this present itself? So it can be latent TB. We'll talk about that. We're going to watch a video. Mostly it's going to present itself with the pulmonary, the respiratory signs and symptoms. Okay. Guys, going through paramedic school, I just thought that TB, the only signs and symptoms you had was respiratory. Okay. But like 1% of TB patients, it can present in the bone marrow. And wreak havoc on those patients through the bone marrow, but usually you're going to see it in respiratory form. All right, how does it present? How might you be like, ooh, you might have TB for the patient? Okay, so if they're coughing up blood, that's a big sign. All right, what else? Again, coughing blood on top of different signs and symptoms. Fever. What else? Typically night sweats. That's another big one. Have you been waking up in the middle of the night like covered in sweats or soaking wet? Have you had any type of fever lately? And guys, again, a lot of other signs and symptoms for different ailments, right? Fatigue. Do you just feel really, really tired? Have you lost appetite? Okay, do you just globally don't feel well? All right, but if we top on those night sweats and that coughing up blood, that's going to raise a red flag for me for TB. Okay, guys, so there is something called latent TB. Somebody can be infected with TB and it's just hanging out in their body, but they're asymptomatic. They're not showing any signs or symptoms. All right. So for example, with that, like me, I had mono when I was 21, 22. All right. It was awful. Felt like I was dying. But I will forever have that virus as part of my bloodstream, my makeup. But I'm not constantly presenting with the signs and symptoms of mono. Right? If I become dehydrated, if I'm not taking care of myself, then it can present itself. It can start to become active again, and I'll have the signs and symptoms. But day in and day out, it's just in my system, and I'm asymptomatic. Okay. What kind of patients are more prone to developing TB? Immunocompromised, yes, but what kind of like environment is a breeding ground for TB? Very close confined spaces. All right.
Talking about that homeless shelter.
Talked about that homeless shelter that y'all will never know anything about, and it's crazy. There used to be a massive homeless shelter at the intersection of Peachtree and Pine, right across the street from Emory Midtown, and that place was notorious for having those people packed in there like sardines. It wasn't a very well ventilated building, and especially during those colder winter months, there were even more people in there to get, out of the cold, off the streets. That kind of damp, close, confined environment, oh man, TB ran rampant, okay? They traced a particular strain of TB all the way in California back to that particular homeless shelter. Like we developed our own Peachtree and Pine TB strain, okay? So close confined spaces, homeless shelters is a really big one. What else? Where else? Prisons, okay? So if we've got these patients that are fatigued, coughing up blood, night sweats, any type of productive cough, we want to ask them, have you recently been around a homeless shelter? Have you recently been in prison? Have you recently been around anyone who has been in either or any of those places? Okay, so that confined space is a tuberculosis loves to run rampant through those. Again, N95 mask on you, surgical mask on the patient. We're going to convey, hey Grady, I'm calling your report. Got a 27-year-old male presenting with productive cough, coughing up blood, fatigue times 3 days, fever of blank. Here are my vital signs. Be advised, possible positive TB. They need to know that so they can put that patient in isolation so that person doesn't get the entire ER sick with TB. Okay. Again, immunocompromised patients, this can be fatal for them. When you guys get ready to go to clinical, we are going to do a PPD placement. Okay, so pretty much we're giving you an inactive version of tuberculosis to see if your body responds to it. All right, typically we put a little injection of a little bubble right here on your forearm, stays there after 2 days. We look at that bubble. If it is really, really angry looking, if it's raised or if it's spread or if it's very red, that means that you have come in contact with TB in some way, shape, or form. Okay. Outside of the States, there is a vaccine that is given at birth for tuberculosis. We have a lot of students who come through that were not born in the US, they receive the vaccine and they react. So we don't typically give the vaccine here in the States, but it is given elsewhere. Huh?
Why don't we?
It's
Like, cause it's like smallpox, why bother? Or
pretty much. Pretty much. There's something else I want to say. Got nothing. All right. Video time.
An estimated 1/3 of the world's population is infected with tuberculosis. 1/3. And here's the culprit: the minuscule bacterium called Mycobacterium tuberculosis. But does that mean 2.3 billion people are sick? Fortunately not. Only a small proportion of them actually become sick. To understand why, let's take a closer look at the bacteria itself. When someone with TB coughs, they expel little drops of saliva that fly into the air. Some of them may contain the TB mycobacteria, which can then be inhaled by someone close by. Mycobacteria then continue the journey down the respiratory tract and into the lungs. That person is then infected with TB. And this is where it all becomes a little more complicated. The body detects the invasion and sends out its first line of defense. This includes special cells called macrophages, which engulf the mycobacteria and transport them to the lymph nodes, where they are neutralized. If they're neutralized, the person will have what is called latent tuberculosis. This means they're infected with the bacterium. They don't have active TB disease, and they're not sick. However, in 5% of cases, the immune system is overwhelmed. The TB mycobacteria multiply and escape, and the person falls ill. This often happens with young children, whose immune systems are not fully developed. In other cases, latent TB can wake up and become active TB. This can happen months later, or even years later, especially in adults with weak immune systems. For example, people who are HIV positive, or who've had organ transplants, or who are undergoing chemotherapy. Once in the lungs, bacteria may spread via the bloodstream or the lymphatic system to other parts of the body, the lymph nodes, bones and joints, the digestive system, the central nervous system, the liver, or the heart. So what happens when someone has active TB? Let's imagine the infections in the lungs, as this is the most common place. The patient starts coughing, has difficulty breathing, and suffers from chest pains. If these symptoms last for more than a few weeks and are accompanied by fever, night sweats, and weight loss, the doctor has good reason to suspect tuberculosis. The next stage is diagnosis, and then treatment. The battle is far from over.
Make a little more sense? Yes, no, maybe so. Cool. All right, so whooping cough. All right, this is pertussis. We've already talked about this in the respiratory. Remember, we watched the video. I got on my soapbox for a little bit. Anybody not remember that? I'll probably get on my soapbox again, but if you've already heard it, then I won't. So again, this is respiratory. This is communicable disease. It can be spread right through those droplets. There is a vaccine for this. Guys, they will even both times. Well, not. Did they do the second time? I think they did. If you are getting treatment, prenatal care while you're pregnant, at that 37-week mark, they give mom the vaccine for pertussis. So mom doesn't get it, the baby doesn't come out and get it from mom type thing. So vaccines, masks, again, guys, it's an appropriate question as long as you're being tactful and professional to ask if it's a pediatric patient if they have received their vaccinations, right? Because if they haven't, I'm seriously concerned that this could be it. Or they could be, too young to have gotten it. They could have gotten it from somebody else who wasn't vaccinated. That's appropriate question for your patient. Just like any of these patients who have a communicable disease that is spread through droplet precaution, guys, even if you don't think that they have TB, but your patient is coughing, right? Any type of productive cough or a dry cough, it is not inappropriate. It is not offensive to place a surgical mask on your patient, okay? Again, that's how we deliver, how we're gonna say that to our patient, like, dude, the cough's nasty, like, put a surgical mask on, right? How can we phrase that if we're worried about like offending a patient or hurting their feelings or whatever it might be because you're concerned about your safety? Because any of you guys want to get TB, meningitis, the flu, anything? No. Okay, so if your patient is coughing, how can we phrase that?
Is there anything that you're coughing up that I don't want?
I mean, that's not a bad question, but are they going to know that?
No.
No.
In a pandemic and putting a mask.
Okay, so yeah, especially in this day and age, I don't think anybody questions that, right? But let's say we're outside of a global pandemic and it is December and it's just cold and flu season.
Just Medicaid.
Or would you just say it's part
Flu
of the
season.
safety protocol? We do that.
Or it is the middle of summer. Hey, so, I gotta make sure I can come to work and take care of everybody and we don't need to be passing, cooties or germs or anything like that around. So, I'm gonna place this mask on you just so you don't get everybody else sick. I'm gonna place a mask on myself so I don't get sick. You could phrase it to where we're gonna be in a hospital where there's already sick people there. So, we're gonna place a mask so they don't get anything different type thing.
This is
So
a
just-
protocol in the British protocol, you know?
Depends on what the etiology is.
So, could you say, we've learned a lot about how diseases are,
Sure.
and as part of a protocol, we wear this mask and we put a mask on.
I wouldn't lie if it's not verbatim black and white in front of you
No, I
that it
totally
is
get that.
protocol.
Totally get that.
But yeah, guys, again, it's when we're talking about moving an obese patient, right? If the patient's like, why are we taking so long to get to the hospital? What do we say? Why are we taking so long? Why can't you and your partner pick me up and put me in the truck? Why do you have to wait on somebody else?
Because we gotta be safe, right?
I gotta worry about your safety and my safety, right? That's not a lie to the patient. So the same reason we're not lying, just make it about the patient's safety, others around their safety when it comes to the mask thing. It goes over a lot better than, hey, you're kind of grossing me out with the mask on.
Could you tell them that you suspect them having so-and-so, like, so just to make sure?
So if you do think they're checking all the boxes to have TB or meningitis, then yeah, that's a fair conversation to have. It is very possible that with what you're telling me and what I'm finding, you could have this bacteria, and we don't want to give it to anybody else. Yeah, that's a fair statement.
If it isn't less more, I mean, we gotta be careful, right? I mean, we're not in a position, to your point earlier, to run all kinds of tests to be defended, right?
So it is possible
Right.
that you could have this.
Okay. But couldn't that also ramp up the patient? Well, you mean I could have?
I mean, not if you have an educational moment with them.
Okay.
Be like, this is far more common than people think.
Yep.
If it's true, I'm not worried about given your vital signs and this and that, but it is easily spread. So yeah, because you're never gonna say I'm diagnosing you with tuberculosis.
Yeah, I mean, dude, you're a paramedic. What?
I mean, I don't even say, my STEMI patients, I'm not diagnosing you with a heart attack. It looks like you're having a
Data
heart attack.
supports, right?
Huh?
The data supports.
All right, MRSA. This is scary stuff.
Hospital infection.
And it's also the superbug. Okay. I'm gonna get on another soapbox here, and it's not for any reason that you might think. Okay, guys, what is MRSA? Who's heard of MRSA? Okay, what do you guys know about it?
Sure, I just got done fighting it.
Infections related to everything.
So this is, a lot of people will refer to this as like a staph infection or staph, okay? So part of the very, very long word up here, the staphylococcus, short term for that is staph. So if you have like a staph infection, okay, a lot of that is directly from this MRSA. Now, this is the little superbug that gets a little scary, because a lot of people don't do what they're supposed to when they get medicines. In particular, what kind of medicine?
Antibiotics.
Antibiotics. All right, guys, why do you get an antibiotic? If you go to the doctor and you tell them blah, 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 and they're like, oh yes, here's an antibiotic, take it. Why would you get an antibiotic?
Bacterial infection.
Okay, you got some type of bacterial infection in your system, in your body, and these antibiotics are supposed to, you take all of the antibiotics, you take all of the pills, and it eradicates, it gets rid of the bacteria. Okay, guys, there's all sorts of different antibiotics under the sun, right? There's different strengths, there's different types. Some of them you take for 5 days, some of them you take for 2 weeks. All right, the doctors make this judgment call on what antibiotics to give you based on your blood work and your lab work and what that bacteria is. Okay, so we call this the superbug because this has evolved. This is a very, 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 very smart bug, bacteria, okay? If you go to the doctor and you get antibiotics, you have to do what? Or you're going to be susceptible to this in the future.
You should take all of them.
You
the way you're
have
supposed
to take every single pill in that prescribed antibiotic. Okay, guys, if you do not take the full duration of that antibiotic, have you ever heard the term, what doesn't kill you makes you stronger? We're not talking about a Kelly Clarkson song or a breakup motto here, okay? What happens if you don't take that entire duration that is calculated to kill off completely, 110% completely kill that bacteria? If you take, let's say, it's a 10-day antibiotic, and after 48 hours, after 2 days, you start to feel better. Yeah, because it's working, doing what it's supposed to. And you're like, oh, I feel better after 2 days. I don't need to take the remaining 8-day antibiotic.
You probably hadn't killed all of them, just the ones that were vulnerable to the antibiotic.
What happens if you don't finish that antibiotic and entirely kill off that bacteria? They say, ooh, the bacteria that's still in your system, because there's still going to be some there, says, thank you for showing that little ace up your sleeve. Now, I have been exposed, that bacteria has been exposed to that antibiotic, and it's learned its secrets. Those antibiotics, or that bacteria that's still alive, it says, okay, I know you now. If I get into your system again, I'm going to evolve because I'm smart, I can mutate. And if you give me the same antibiotic next time, I know how to work around you and it's not going to kill me off. That's why this MRSA is known as the antibiotic resistant bacteria, because if you're not taking all of your freaking antibiotics like you're supposed to, you're setting yourself up to say, have a bacteria that has evolved and mutated to say, you showed me that before, you didn't completely kill me off, now I'm smart, that's not going to work on me anymore. Okay, so if you didn't know before, you do now. This is your PSA. If you were ever prescribed antibiotics, take every single pill, even if you're feeling better after half of the dose. It doesn't matter if you're feeling better, it's working, but you got to kill it off in its entirety, or this could be you down the road. Okay. You can acquire MRSA in a hospital setting if the equipment's not being sterilized, if PPE is not being used, if they're not washing their hands, all that stuff. You hear about that surprisingly a lot, like hospital acquired MRSA or staph infection. So, yeah, guys, this is nothing to joke around about. My cousin actually became paralyzed from staph. He was a wrestler in high school. That makes you more prone if they're not really cleaning off those wrestling mats. It's a damp, moist, usually dark environment. When they roll the mats up, a lot of wrestlers get staph. So he was prone to getting staph infections. He had a cut on his arm and got staph from that. He went to 4 different hospitals, 4 different ERs, and he was complaining of back pain. And they thought he was just trying to get painkillers. They didn't take him seriously. They didn't draw blood. And the last hospital he went to, when they told him, hey, we can't give you any, here's some ibuprofen. Like, we're not taking you seriously. He couldn't get off the stretcher. He was paralyzed from the chest down because it infiltrated his spinal cord and it went untreated. And this is a big problem. Okay. So again, with MRSA, we might have a source of infection, like a recent injury. Let's look and see if it's got that nasty, like it's red, it's angry, it's swollen, it's got like that pus coming from it. And we might even be going into the area of what kind of shock? Septic shock. Okay, if it gets in the bloodstream and it starts to target different systems and different organs. Yes, sir.
Did they leave backwards still in EFT psych, I remember, right?
No.
The backward AKT or broken nerves?
Correct.
Okay. Did we cover from that?
He sued the hospital.
Yes. His mom is.
How old was he?
He was 25. It eventually killed him. So, Again, pain is subjective, but make sure you are not getting tunnel vision every assessment, every question, every vital, every patient, every time, so you don't miss something.
So if you do take all the meds, right? I'm asking because my oldest son wrestled, and he did have staff several different times, and it did get ugly, we had to go to the hospital for it. I didn't realize that it could go to that, but.
Yep.
So when you do that, it's not letting it go into the system.
No. So,
I'm so sorry.
that's actually who my youngest is named after. So, just be aware. Global health issues, MERS, we are having kind of a derivative of that, kind of a repeat with this pandemic. Again, guys, a lot of these things are going to be specific to different countries. If they cross borders, we turn into a pandemic. Ebola, that was the last attention getter of the globe, right? This was the transport team. Everybody here worked at Grady. This was actually my paramedic instructor. She was my FTO when I got hired. She's a superhero, right? But again, technically it became a pandemic. Sucks. Does anybody talk about Ebola anymore?
It's a scary way, it's a pretty spectacular way to die.
Is it still running rampant, especially in the country of Africa?
Yes.
Yeah. Is it still killing millions of people? Yeah. But it's not, okay.
It just recently flared up again.
Okay, yeah. So guys, Ebola, it's bad. Pretty much it will get into your system and you leak out of every single orifice until you go into a state of hypovolemic shock and it kills you. Okay, so not a fun thing to have. Again, we changed kind of protocol procedure with Grady when this was going on. What did we ask every single patient? What did you get asked everywhere you went, maybe now? And if you remember the whole Ebola scare, have you traveled outside of the country in the past 21 days? Have you been around anyone who has presented with these signs and symptoms in the past 21 days? Why was that 21 days so important? That's the incubation period, okay, specifically for Ebola. She actually transported patients while we were around her in the academy, and we had like a countdown on the dry erase board. 4 days until Gail's considered Ebola free. Like, so that incubation period is really important to remember. Okay. Comments, concerns? Guys, wear your PPE. Ask questions. Make sure you're getting all these puzzle pieces. You're putting them together, and you're kind of sounding that alarm, if you will. If you're bringing these patients into the ER, hey, possible positive TB, meningitis, anything like that, if they need to go to isolation to protect the other patients in the ER. Okay. Okay.